All right. Three, two, one. Needle
Needle
pod.
Pod. Oh, so good.
We're so off.
Our fourth episode and our best intro yet. Don't stop listening. This is going to be
Great.
fire.
We're
Man,
getting
this is
good.
exciting. Ellie, we're back. It's our fourth episode. This will probably be dropping after the first of the year. We're doing the bi-weekly thing. But at the time of this recording, it's our first episode just went live. We're on Spotify and Apple Podcasts at this point. So thank you to our 2 listeners. It's early, but boy, do you mean a lot to us. I will never listen to myself on Spotify. So maybe my mom, maybe a colleague, a close friend.
Maybe someone that got lost on Spotify.
Yeah. Got lost in the Needle podcast, but we're officially live. To circle back, before we jump into our new content, last episode, I asked what was more cringe, the buried to the handle, like the full buried needle to the shaft, or that needle that has like 2 or 3 or 4 inches, like a needle way longer than was necessary. And I was actually encouraged that the Instagram poll was pretty tight. It was 54% with you, didn't like the buried needle optic, but 46% really don't like the 4 inches sticking out, which to me that says it was a good question. I mean,
It's a tight race.
I don't want to send any like landslide, because then I feel stupid for even asking. If everyone's like, obviously
Duh.
it's the buried one.
Yeah, that was a good one.
So we're live on Spotify and Apple Podcasts, which makes me embarrassed to say I have my ring light on. I normally put on a new shirt, mousse the hair, or I don't mousse the hair, I style the hair. But we're not actually live on camera anywhere.
Except for on our little clips on Instagram, which is fun.
Which are always claymation. Claymation did you dirty on that last little teaser clip. But we're Muppets or babies. And maybe we'll go live on YouTube at some point where we'll be happy we did. But I just feel vain at this point when I'm preparing for our podcast.
That's okay. You gotta look good, feel good, think good, do good. That's my motto.
Oh, I like that.
Yeah.
So you're saying we sound better when we look better.
Exactly. Exactly. All right. What's the topic today, Paul?
So a ChatGPT inspired topic, but I like it. And I like the way ChatGPT doesn't just give you ideas. It like makes them sound cooler than I would have. So the title is Dry Needling Plus Movement, the New Standard of Care. And I love that because that really embodies a paradigm shift that I'm sure you're aware of. And I'm sure if you're listening and you were trained, maybe not even a decade ago, maybe like 5 to 10 years ago, versus if you take one of our courses now, we use the needles a little differently. And I think that filters through from the old school and the new school. But what we say to our patients, what we do with our patients is also a lot different. Meaning, I remember how I used to teach, and I remember that first course I took. The company gave us like, here's a 1-pager that you can give to your patients after needling, like what to expect and some things you can do about it. And we would prepare the patient. We would tell them to expect 48 hours of soreness. That's normal. That's good. We actually caused some tissue trauma and some inflammation, and the body's going to heal it. But then what the patient should do was all pretty passive stuff, like static stretching, maybe some very light, like laying on the table exercises. You should hydrate, but the opposite of movement, which is now the answer. And before we give our fully biased, large sample sizes of success in the clinic, but before we give our biased views, we're going to dig into 2 different research publications. And what's fascinating is there's really only 2 that we could find that look to answer this question, specifically, not even for clinical outcomes, but specifically for post-needle soreness, or like that patient experience immediately off the table, 24, 48, 72 hours later. Is exercise better? And in one study that we'll unpack, what type of exercise. So how about you drop in, let us know what 2 citations we're looking at. If I can find a way to drop the links in the show notes, I'll put it there. But let's hit the research first.
Me? All right. So we're looking at, first one is effects of low load exercise on post needling induced pain after dry needling of active trigger point in individuals with subacromial pain syndrome. This is by Solom Moreno et al. And yeah, it was interesting. It was a single blinded randomized controlled trial with up to 72-hour follow up. And they were looking at what was interesting about this study, I think, is they looked at people that actually had symptoms, right?
Yep.
Versus the other study was looking at folks that had latent trigger points, which we'll talk about in a minute. And I think the biggest takeaway from this is, after 48 hours, most of the control group, the placebo group, and the intervention group all seem to be the same, which is kind of our verbiage that we talk about, is that from one of the other studies that looked at trigger point needling versus layering and e-stim, it's around 72 hours where things start to like converge when it comes to outcomes or symptoms. And so this is saying something similar, right? All of those groups are going to have improved symptoms after 48 hours. But what was interesting is that the exercise groups, the low load exercise, reduced that post needling soreness in folks that had dysfunction in their infraspinatus. So I think that's, again, obviously our bias when it comes to symptoms or to treatment models. So that was cool that that reinforced our bias a little bit
Yeah, and this is
versus go on.
sorry. I mean, this is the one that I bring up on courses. And I mean, typically it comes up if it's not my idea with the question on like, what do we do with our humans right off the table? Or even someone that was trained previously and says, so you're saying we should load a patient right after needling? And the answer is yes. And
Mhm.
we'll talk about the successes we've had again, but this is the study I point to. Group A, so everybody got their infraspinatus crushed with pistoning. So, I mean, the immediate layer to both these studies is, yeah, the diagnostic emphasis or the criterion of trigger points, which immediately puts a layer of like, I mean, suspicion in my mind, but it also trickles into like how they use the needle. Like you said, this group active trigger points. So these were subacromial, like shoulder pain, most of them anterior shoulder pain, where when they dug in infraspinatus, ooh, that's my spot. That refers the front of my shoulder. They went in, crushed it. Everybody got pistoning. Group A went out and did the exercise thing. Group B had an unplugged ultrasound unit, and Group C just sat in a dark room, no intervention. And yeah, you already hit the key points. It's worth saying, not to get ahead of ourselves for the next study, but no matter what was done in the silos of these research studies, 48 and 72 hours later, all groups are the same. And I mean, that's where the narrative that we used to give Gladys came from of like, I know you're pretty sore. Like Gladys is limping out of the clinic after we just crushed medial gastroc, but we're like, therapeutic benefit things. This is healing. This is therapeutic, Gladys. You're going to be fine in 48 hours. And it was true, but this is one of the studies that reinforced that.
Mhm.
But what this study found that, again, not to get ahead of ourselves, the other one didn't, is that the exercise group had a better 2 minutes after and 24 hours after when it came to that
Mhm.
post needling soreness. So that gives a very patient approachable layer to why we should be doing active versus passive stuff.
Yeah, love it.
And I mean, let's go right into study 2 because this one was a
Mhm.
little more complex,
So
findings
this was
less supportive.
yeah, this was the efficacy of exercise on post needling soreness, a randomized controlled trial by, I'm going to butcher the last name.
That's
I
why
don't
I'm
know if it's
making
a
you that's why I'm making you read. These are both Spanish groups. You did
I
great on the
don't
first
know.
one.
I don't know if this is a silent or a soft C or a hard C, but I'm gonna go with the soft C. So Disolia. I don't know.
Solia, which sounds Italian, but
Italian.
she's from Madrid, Spain. What? You should
um,
just read the rest of them.
I'm good.
No, you don't have to.
At all.
Desolia
Um,
et al.
Yeah, that's my go-to when you don't know how to pronounce everyone. So this was looking at differences in types of exercise with a control group as well. So they looked at concentric, eccentric, isometric exercise on post-treatment soreness after dry needling, and this was in a group that did not have active pain, but they had latent myofascial trigger points in the medial gastroc, which I feel like if you dig around hard enough in most people, you can find some latent trigger or like some top bands in that tissue. this was, again, a randomized control trial. Off the top of my head, I can't remember how many folks were in the study. Um, but yeah, so they looked at those 3 protocols, pistoned for they were doing trigger point dry needling, pistoned for up to 50 insertions, and kind of they looked at the amount of twitch responses that were received during that 50 insertions, and then they
Which anybody out there that's laid on the table for medial gastroc, 50 is a large number.
that's a lot.
I
Yeah.
don't care how cool you think you are, 50 is a lot. So I mean that jumps out
It's
to me. But
aggressive. Yeah.
sorry to jump in.
No, you're good. So they were looking at post-needling soreness and pain pressure threshold immediately following the needling, and then also following the exercise group. And I'm a visual person, so I like to jump down to the different charts and kind of dissect those a little bit. And if you look at statistical significance, I don't believe the groups were statistically different when it came to pain scale and pain pressure threshold, but there are some things that are interesting to look at when it came to the trend lines of the groups. And so if we look at figure 2 in the study, so if you guys have this study accessible, pull it up. Figure 2, if you look at the isometric exercise group, which is the triangle there, post exercise seem to have the most drastic decrease in pain right right away from that, while the eccentric exercise group seemed to have an increase in symptoms immediately after exercise. But then as that trend line continues, all of those groups, the pain seemed to reduce significantly within the first 12 hours, and then they seem to kind of plateau with the 48 to 72 hours, where all of the groups, including that control group, were different or were the same outcomes there. So,
Yeah.
um,
And I love the visual as well, because first of all, this is a visual of what was already said. Every group, depending on where they started and where they kind of were at 6 hours, 12 hours, every group is in pretty much the same spot 24 hours later. Um, it is interesting to dig into the nuances though, because yeah, control group didn't get exercise, concentric, eccentric, isometric. It's interesting to see what happened immediately after the exercise and then 6 hours later. And again, you said there's 70 subjects here, so it's like less than 20 per group, so not a massive sample size. But from this visual, looking at pain, 2 minutes after needling, then right after exercise, then 6 hours later, concentric is the most intriguing trend line for that post exercise down to 6 hour soreness.
mhm.
Um, but again, a more cynical
Oh
eye
yeah.
would say they're all pretty much the same 24 hours later.
Yeah. What I do find that's interesting though is 24 hours versus like traditionally you mentioned this earlier, we would say up to 72 hours you might have that post-treatment soreness. And what this is saying really is like significant of that reduction of symptoms is going to happen within that first 24 hours.
Yeah,
Um, which
great
is
point.
kind of the verbiage that I use with my patients these days. So, um,
Yeah, even
yeah.
back in my trigger point crushing days, and I mean, I would crush gastroc. I mean, when you're an early needler, that is a fun tissue to treat, but easy to overdose. I was documenting, moderate to severe soreness reported off the table. But yeah, the number of clients that I came back, I'd read my note from the last visit. I'm like, oh, that's right. Your gastroc was pretty sore. How long did that last? And I think your
Mhm.
point is good. Is rarely did that patient say, well, it lasted 3 days. It was more of like, oh, yeah, I forgot about that. Like, I was fine by
Mhm.
that night, or I went on my run the next day and I felt fine, didn't even notice it. So, yeah, maybe even if you're still out there doing this thing, we can reel in our timeline like 50% and say it's not 3 days of soreness. Like, if we can find ways to get through the next 24 hours, we'll be fine.
Yeah. Yeah. And I think what's really cool is that that is like the perfect opportunity for us to like creates that window of opportunity for us to layer in some other pain mitigation strategies, which is, physical therapy. If we look at all of the tools we have, it's not just needling, right? Needling is just an efficient way to see some change in symptoms pretty immediately. But then physical therapy is the coolest profession out there. I'll be a little biased in that we have so many other tools that can help with that pain mitigation immediately after. And one of those is we know from other research is exercise, right? We know that increasing cardiovascular system is going to increase blood flow, is going to help with inflammatory chemicals, all of those things. So if we start layering in some of that, I think that's going to be helpful as well. So really cool.
Yeah.
If we zoom down to figure 3, it looks at pain pressure threshold. And again, for most of these, they're not statistically different. But what they did find here was that the eccentric group, or visually, the pain pressure threshold increased the most following exercise in the eccentric loading group. So again, just
Mm.
something to
Fascinating.
take into your clinical practice, whatever you want to do with that. But yeah,
Fascinating.
yeah.
So, if we overlap those two thoughts, the eccentric group seemed, I mean, again, no statistical thing. We're just making assumptions based on the trend line or like where the dots moved. But
Yeah.
the eccentric group didn't do the best. In fact, they were the worst post exercise compared to the different types of exercise for pain, but best for pain pressure threshold.
Yeah.
That's fascinating to me. I'm sure I'll have a classier explanation at some point, but I mean, we stress the tissue maybe in the most stressful way, which if our goal is changing pain, might be a lot or might be the most savage way to load that tissue right off the table, but
Yeah.
does some cooler neurophysiologic stuff.
And I think that kind of points to also like perception of pain versus like an objective measure of pain, right? Like pain pressure threshold is one of the only objective measures that we can have to look at nociceptive input, right? And versus just a qualitative perception of pain. Just, yeah, by how they feel,
Yeah.
So
So unfortunately, this study didn't scratch the itch that we wanted it to, which is just tell us which type of exercise is the best. And we just, man, we wanted that, whatever it was, eccentric to outperform everything else and or whatever. Just tell us what to do. It didn't do that. Um, let's jump away from the research now and just say we are decidedly at the point where we move our patients. We move our patients. And I mean, whether it is that first study, which is if we do a little bit of loading or movement now, the next, 0 and 24 hours will be the least painful if pain or soreness from the needle is part of our goal with that patient, but also just appreciating what all of us who needle know is like we have very powerful short-term changes from a needle. And we're at the point where we're not just going to sit in a dark room for 48 hours and say, let's let things just kind of take their course naturally. Like we have window of opportunity. Maybe there's even patients where the main goal isn't pain. It's we have a window of change in neuromuscular function that we want to reinforce. All of this I'm leading you to is we now move our patients. Our cues, our 24, 48-hour windows, our 1 week after needling is movement based. Some folks that means, can you go on a walk this evening? Don't just sit in your car, then sit on the couch, then go to bed. Like we just did 2 exercises and it would be a great evening to go on a walk. Other folks, it's like, yeah, you can totally send that CrossFit WOD, but let's decrease the load. Let's scale this movement. But yeah, I want you to move for sure. So I mean, I want you to give me some of your successes, but I also want you to give me some of your go-to things. And I mean, we could match the research and say you just crushed infraspinatus for shoulder pain, or you just hit medial gastroc, which we know is a tissue that people are going to feel off the table with a needle. Maybe a
oh
lot
yeah.
less with E-stim, but they're going to feel it. Or anything else. I mean, you crush upper trap, you crush glute medius. I mean, give me, whether it's like the type of exercise or a specific exercise, give me some of your go-to things with high success.
Yeah. So I I obviously live in the pelvic floor space, so I would say a lot of what I'm treating is pelvic girdle pain, low back pain, those sorts of things. So I have more data on that patient population a little bit, so I can speak to that. And then I do want to kind of speak to gastroc a little bit, and I think where the eccentric might be helpful there. But so patients, so I treat a lot of adductor dysfunction. I treat a lot of glute dysfunction. And I do oftentimes start with, well, first I'll kind of get their blood flowing. So I'll have them hop on the bike for 2 minutes just to kind of continue that blood flow, increasing vasodilation, all of that stuff. And then I layer in I like to start with an isometric. I think if someone is in pain, isometrics are analgesic. That's something that, again, we know in the research, especially for things like tendinopathy, right? And so isometrics can be a great way for them to continue that pain mitigation past that 24-hour mark. So I think that's where I usually start with folks is an isometric. So for my adductors, I love a Copenhagen plank. So this is a plank where your top leg is on a bench and you're unloading that bottom leg as much as you can tolerate while you're loading that top leg adductor. Then for glutes or like lateral hip stuff, I like a side plank with a clam, right? So we're
Mm,
taking the clamshell and we're leveling it up a notch there. We're getting some good core activation. We're getting lateral like stabilization or activation there. So those are my two kind of go-tos when it comes to working on either side of the pelvic girdle. And I typically will start with isometrics there. I do want to pivot a little bit and talk about like gastroc. Typically, we're treating gastroc for a foot related pain or a tendinopathy, like an Achilles tendinopathy. And I think
yep.
those folks do really well with eccentric loading. And I think it's working into that range of motion. And I'm not sure, maybe you have a different clinical perspective there, but I think that may be why I might load eccentrically with them a little bit
Yeah.
more.
I mean, yeah, let's start with gastroc because I think they even mentioned it in the discussion of that second research study we said, and ultimately they acknowledged, um, state of the condition or phase of injury is probably the biggest determinant for where you go with exercise. Which I mean, maybe it's good we didn't see a big difference attached to needling because that is always going to be the answer. And I think we don't see just like pain-free gastrocs in the clinic. We see Achilles tendinopathy and foot pain.
Mhm.
Um, so I think to say what they said the same way is like what's going to dictate how you approach that gastroc with isometric or eccentric or concentric is the phase of the tendinopathy. And I mean, I recently took extremity management through ICE, Lindsay Huey and Hannah Kiyohara down in Portland. And if you need to dial in your tendinopathy game, like your assessment, but also your loading strategies, your red, yellow, green light, or like when you start with isometric versus eccentric. I mean, that's the course. And I mean, that's
Mhm.
what gives you the best answer. Um, I agree with you, which is I think for gastroc, a two joint type 2 fast twitchy muscle, eccentric, if the patient can tolerate it.
Mhm.
Eccentric is probably where my brain goes first versus I guess that shoulder. I see a lot more scenarios where you start the higher irritability, the less range of motion, where you start more isometric.
Mhm.
So I think it's all
Yeah.
fair. And I mean, I love the Copenhagen plank and I love that pearl for the pelvic realm. If you were to ask me shoulder wise and even trap sometimes of like what do I start with, irritability dictates the most, but I have not found a shoulder that can't tolerate a carry, a suitcase carry. It's the
Mhm.
safest anatomical position for your shoulder. I don't care how limited your range of motion is, how irritable it is. Like I can put something in your hand, tell you to hang on to it, and we can walk. So, I
Yeah.
mean, if you're saying there's some shoulders out there I would never load, I still would argue you can do isometrics and you can do a carry. You can find ways to load that. And what I love about a carry, especially if it's heavy enough, is you don't just get the shoulder girdle like, you have a heavy weight trying to suck the humeral head out of the acetabulum and it's like just fight against that, suck it back up in there, but you carry something heavy enough for long enough as you get some trap as well, which is very
And
helpful.
and core. What I liked what you mentioned there is if you load it heavy enough. I think so many people underdose a carry. Like this should be challenging where we're fighting to kind of maintain that glenohumeral like stability there. And so I think we should do a whole other topic, a whole other podcast on the deltoid and loading the deltoid and,
Oh boy,
touching
I
on
would
your
love
favorite.
that.
Because I do think that I see people in the clinic oftentimes that are like scared to increase that load a little bit, but if you're not getting to that fatigue point there, then you're underdosing
For
that
sure.
isometric, right? So,
And you already mentioned lateral hip, but I mean, being cash pay for as long as I was, people came in knowing that they had a weak glute medius. They had their library of 12 exercises, their clamshells, their banded clamshells, their side steps, their monster walks. What I found, I mean, first of all, needling was something different and off the table. A lot of times you get like,
mhm.
ooh, it does feel different. And typically different meant better. But a lot of times I'm like, I don't need to find a fancier exercise for you, but I think you can handle more than that yellow band around your knees for the side steps. It's like, let's get a much heavier band, put it down at your ankles or knees and ankles, and like, let's do the same thing kind of, but I want you to feel it. Like we're at the point where we just have to build a bigger, stronger muscle, and the stuff you're doing is not that.
Yeah. Yeah, for sure. We've kind of pivoted from the original topic, but I love that. It's like, let's load them up.
Beauty of the unscripted podcast.
I love it. Yeah. So yeah, to summarize here, I think some exercise, some movement is better than nothing, right? Like keeping movement going, and there's no wrong answer when it comes to type of exercise. Go based off of irritability of their symptoms, for that piece. And load is our ultimate love language, so getting them more resilient and stronger is better, really. So,
Hell yeah.
yeah,
All roads lead to load. Load
that's
is the
right.
love language. Dr. Lindsay Huey.
Yeah,
So we've been sitting here for 30 minutes. Maybe
I
we
know.
should we should get out there and move. I think
For sure.
so. Again, I'll drop citations in the notes if I can. We're still new to this. We're amateur podcasters, but this is our 4th episode. We could ramp things up a little bit.
Yeah. I think this was
Any
our best one.
It was I mean, I think we're getting better. What we're
Not
not
that
getting
great.
what we're not great at is our sign off. Do you have a good sign off for us?
I don't have a good sign off for us.
We need like a Toodaloo Needle Crew or like something. So
I love it. You'll
we
have to
want
say it every time.
yeah, lots of Rebel and Crew going on at our house. So you need like that sign off where they all do like the wiggle and wag. But all right,
Yeah.
team, we are gonna shut this one down. Thanks for joining. We'll catch you next time. Thanks, Ellie.
See ya.